Okay, so it's my pleasure to introduce Dr. Sibel Deviren from the Orthopedic Department of Orthopedic Surgery here at UCSF. And she's going to talk today about the clinical phenotype of muscle-related chronic low back pain. So Sibel, please go ahead and share the screen.
Thanks so much, Roland. Good morning, ladies and gentlemen. I'm Sibel Deviren. Today, I will talk about clinical phenotype of muscle-related chronic low back pain. What are the possible muscle-related phenotypes? The most common one we see is the weakness in paraspinal muscles. And even though the weakness in paraspinal muscles is the most common problem we see, interestingly, when paraspinal muscles are too strong, they are able to cause pain too. And just having imbalance among the core muscle strength is enough to cause chronic low back pain. And one of the other reasons we see in the clinic as a muscle-related chronic low back pain mismatch between muscle strength and sagittal spinopelvic alignment. And the weakness in paraspinal muscles could be caused by deconditioning, disuse, atrophy, and those two conditions are easy to address with exercise programs. We are able to see denervation, atrophy, and because of the inflammatory process in the spine, unfortunately, paraspinal muscles are able to go through fibrosis and fatty infiltration, which are not that easy to address with exercise programs. And very rarely, we also do see myopathy of paraspinal muscles. Denervation is paraspinal muscles are not getting enough nerve supply. When the spinal nerves are getting compressed in the spinal canal or in the foramen where the nerves are getting out of the spine and able to affect the nerve supply of the paraspinal muscles, which is able to lead to denervation, which is a combination of fatty infiltration and atrophy. We did compare paraspinal muscles in subjects with symptomatic and asymptomatic lumbar spinal canal stenosis. We had 11 female subjects in symptomatic group and 9 female subjects in asymptomatic group. And we measured paraspinal muscles cross-sectional area and fatty infiltration. We showed the fatty infiltration in paraspinal muscles was more significant than the atrophy in subjects with some symptomatic spinal canal stenosis. The symptomatic group had smaller multifidus muscle cross-sectional area, even though the difference between the groups were not statistically significant. And as we all know, denervation, aging, degenerative disc disease, and chronic low back pain are all able to cause fatty infiltration in paraspinal muscles. Most of the time, fibrosis and fatty infiltration, they go together, especially in patients with degenerative disc disease. And we did look at the negative impact of MODIC-1 degenerative disc disease on paraspinal muscles. We had 9 patients with MODIC-1 degenerative disc disease who had baseline and follow-up MRIs for at least a year. And we look at the changes in paraspinal muscles volume and changes in fatty infiltration. And we showed fatty infiltration in multifidus and psoas muscles at the level of MODIC-1 degenerative disc disease significantly increased. And psoas and multifidus total volume from L1 to sacrum significantly decreased on follow-up MRIs, even though the number of patients we had was 9. This data and animal studies and other clinical studies also support, in addition to painful disc, patients with MODIC-1 degenerative disc disease develop atrophy and fatty infiltration of paraspinal muscles that cause poor physical performance. and disability. We also showed patients with degenerative spondylolisthesis who choose to have surgery had significant instability and more fatty infiltration in multifidus and erector spina. We compared the paraspinal muscles volume and fatty infiltration in 77 subjects with degenerative disc disease who choose to have surgery with those who did not. And interestingly, the subjects with degenerative disc disease who choose to have surgery had bigger multifidus and erector spina muscles, even though we expected them to have atrophy. And very likely instability in the area stimulated muscles to get bigger, but the muscles at the same time start fatty infiltration process, which did affect their contractile abilities. And those patients didn't get better with non-surgical treatments. Even though degenerative spondylolisthesis patient population is a defined chronic low back pain patient population, it is not a non-specific chronic low back pain patient population, but we do have patients with degenerative disc disease who do have mild instability and mobility at the level of degenerative disc disease, who also possibly go through this process. And the other problem we see is the fibrosis, which usually go with fatty infiltration because of the inflammatory process in the spine. Just recently published, there is an increased fibrogenetic gene expression in multifidus muscles of patients with chronic comparing to acute lumbar spine pathology. And even though the most common problem we see, the weakness in paraspinal muscles, and sometimes paraspinal muscles are too strong. Interestingly, some patients, they do have a great paraspinal muscle mass. Hodges and his friends compared patients with chronic low back pain with people who don't have low back pain. And they showed patients with chronic low back pain, unfortunately, are not able to relax their paraspinal muscles when they stop using them, versus people who don't have low back pain are able to relax their paraspinal muscles when they stop using them. And most likely those patients with very strong paraspinal muscle group are able to go through this spasm vicious cycle because they are not able to relax their muscles. The other reason when the paraspinal muscles are too strong to cause pain, when the paraspinal muscles are really strong, unfortunately, they are able to increase lumbar lordosis and able to cause misalignment, which I will talk about this later more. And just having an imbalance among the core muscles without having any changes in the disc, the joints, also able to cause pain. When paraspinal muscles and hip flexors, when they are stronger than hamstring, gluteal, and abdominal muscles, this is able to create imbalance and cause pain. And then reverse is also true. Hamstring, gluteal, abdominal muscles being really strong, comparing the paraspinal muscles and hip flexors, are able to cause pain too. But it is important to think about those problems when we see patients, and those problems are easy to correct with exercise programs, but that if we do not think about them, we cannot help those patients. And the other problem we see in the clinic, mismatch between muscles strength and sagittal spinopelvic alignment. When paraspinal muscles and hip flexors are short and strong, they are able to increase lumbar lordosis. And when hamstring, gluteal muscles and abdominal muscles, when they are short and strong, they are able to decrease lumbar lordosis. And we are able to measure spinopelvic curves. And we all know that everybody has lumbar lordosis. And the pelvic incidence defined by the position of the sacrum in the pelvis. Some people, they do have more horizontal sacrum. Some people, they do have more vertical sacrum. And lumbar lordosis needs to match with the position of the sacrum in the pelvis. We would like to have 10 degrees difference between pelvic incidence and lumbar lordosis to avoid sagittal spinopelvic misalignment. When people have more horizontal sacrum and they need higher lumbar lordosis to match the position of the sacrum in the pelvis, that's how they are able to ambulate efficiently. And when people have more vertical sacrum, they need lower lumbar lordosis. And sometimes there's a mismatch. And this is our first patient. Actually, we did measure the sagittal spinopelvic alignment in chronic low back pain. This patient was 34-year-old male with chronic low back pain. He couldn't walk more than 4 or 5 blocks. He tried all possible non-surgical treatments. MRI was almost within normal range. I really couldn't explain the pain. The patient was really reasonable, didn't look like he had any psychosocial issues. Paraspinal muscles were in great shape. And then we decided to measure the sagittal spinopelvic alignment for this patient. And it turned out that lumbar lordosis was really high. And we tailored the exercise program. We did recommend more stretching exercises for paraspinal muscles and hip flexors, and more strengthening exercises for hamstring, gluteal muscles, and abdominal muscles for this patient. And we were able to decrease the patient pain. And after this patient, actually, we decided to determine the prevalence of sagittal spinopelvic misalignment in a cohort of patients with chronic low back pain, refractory to comprehensive non-surgical treatments. We had 82 subjects with chronic low back pain. We did measure their sagittal spinopelvic alignment. Interestingly, 1/3 of those patients had spinopelvic misalignment. 1/3 of the patients who had spinopelvic misalignment had totally normal lumbar spine MRI, and 89% of patients who had spinopelvic misalignment had higher lumbar lordosis comparing to pelvic incidence. And interestingly, some of those patients didn't have misalignment when we first saw those patients. And we had one interesting patient with modic 1 degenerative disc disease who did well with comprehensive non-surgical treatments. And the patient did come back with a different kind of low back pain in 3 years. We provided the same care and the patient didn't get any relief, which didn't make any sense. And we decided to measure the patient's sagittal spinopelvic misalignment to see whether there's any misalignment. And it turned out that the patient ended up having higher lumbar lordosis comparing the pelvic incidence, which he didn't have when we first the patient 3 years ago. And we thought that this was because of excessive paraspinal muscle strengthening, ended up improving the strength of paraspinal muscles and ended up increasing the lumbar lordosis and created mismatch between pelvic incidence and lumbar lordosis. We tailored this patient exercise program as well, and we were able to decrease the patient's pain. And in summary, the weakness in paraspinal muscles is the most common problem we get to see as a muscle-related chronic low back pain, which are caused by deconditioning, disuse atrophy, denervation atrophy, fatty infiltration, fibrosis, very rarely myopathy. It is difficult to address denervation, atrophy, fatty infiltration, fibrosis, and myopathy. It is easy to help patients with deconditioning and disuse atrophy. And when paraspinal muscles are too strong, unfortunately, they are able to cause pain too. And just having imbalance among the core muscle strength is enough to have low back pain, which needs to be considered. And currently, nobody in the clinic is measuring the patient's sagittal spinopelvic alignment regularly, but I think we need to measure them regularly and then check to see whether there's any mismatch between muscle strength and then sagittal spinopelvic alignment. Why all those informations are important for us clinically? Because we need to know the paraspinal muscles condition. I mean, some muscles are weak, some muscles are strong, some muscles are just deconditioned, some muscles do have major fatty infiltration. And we also need to know the imbalance among the core muscle strength, which is easy to address with exercise programs. And sagittal spinopelvic alignment is important to know, which is able to affect our exercise program. And I believe exercise programs have to be tailored individually. Not every tight hamstrings needs to be stretched, because some people, they do need low lumbar lordosis because of the position of the sacrum in their pelvis. And tight hamstring is able to decrease lumbar lordosis. Not every paraspinal muscles need to be strengthened, because in some situations, it could be, it might have a negative impact on patient's clinical picture. And I also would like to talk about possible research questions from this presentation. And I think we need to find the best possible combinations of sagittal spinopelvic alignment with balanced core muscles for lumbar spine. Most likely this is not just single combination. I believe there will be multiple combinations which would be the best suit for spine. And we need to find out which combinations could create the least degenerative changes. And we need to tailor exercise programs individually based on this information. And the other question is whether we are able to use those tailored exercise programs for preventive purposes, because 90% of people in the world, they end up experiencing low back pain at some point in their life. It is such a common problem. Another problem is the fatty infiltration and fibrosis in the paraspinal muscles, which is the end product of the inflammatory process in the spine. And most of the time, if it is advanced enough that we are not able to help that much to those patients, and whether this process is preventable or reversible. There are recent animal studies has shown that mesenchymal cell injection into disc is actually able to reverse fatty infiltration and fibrosis process in the paraspinal muscles. And not every patient has fatty infiltration and fibrosis, even though they do have the degenerative changes. And we need to find out who does develop those changes and how some of them are able to prevent developing those changes. And is there a point that the fatty infiltration and fibrosis in paraspinal muscles is irreversible, that we may not be able to help those patients? And thank you.
Okay, thank you so much, Sibel. That was a great presentation and a nice overview. So we have a couple of questions here, and we also have plenty of time for a discussion because we are way ahead of our schedule. So let's start here with Wolf. He had the first question. How about anatomical variations in pelvic incidence?
Yeah, I mean, as I said, pelvic incidence is defined by the position of the sacrum in the pelvis. And it is like a signature, and everybody has their own pelvic incidence that we are not able to change. And yes, there's a big variation among people. Some people, they do have very horizontal sacrum. Some people, they do have more vertical sacrum. Some people, it is in between. but then everybody has to match their lumbar lordosis with the pelvic incidence to be able to emulate in a most efficient way. I'm sure that there are people who do have the mismatch and they don't have any pain, but there's interesting patient population who do have the mismatch without having any lumbar spine MRI changes, and they do have pain.
Okay, thank you. So there's another question from Dr. Poppert from USC. What measurement do you use to determine weakness in paraspinals? Are the paraspinals strong or are they hypertonic? How do you determine they are too strong?
I mean, unfortunately, right now, clinically, we cannot really determine. All I'm able to do is I'm able to look at the lumbar spine MRIs. And on the MRI, I'm able to see whether the paraspinal muscles are in great shape, because some patients, they do have great muscle mass versus some patients, they do have major fatty infiltration and atrophy in their paraspinal muscles. We do look at the MRI, we do check multifidus, erector spina, and psoas on the MRI, and then decide about the condition of the paraspinal muscles.
So it's not a clinical assessment, it's more a X-ray, an MRI interpretation.
I mean, we are able to measure the muscle strength, which is just the regular 1 to 5 muscle strength measurement, but it's not a quantitative measurement. But I do, when I see patients in the clinic, I do look at everybody's paraspinal muscles on the MRI to check whether it is kind of normal paraspinal muscles or really hypertrophied paraspinal muscles or more fatty infiltration or more atrophy, whether the changes are more at the lower levels or at the all lumbar spine levels.
Okay, so there's another question from Dr. Batorsky, UNC. In some cases, is it possible that having stronger paraspinal muscles could be due to overcompensations from injuries in other parts of the body or movement patterns?
I don't think so. I think all the patients I have seen with a great muscle mass, they are all the patients who have been exercising regularly, and I would say very likely over exercisers. And there is one patient that I saw who had hypertrophied paraspinal muscles because of a genetic disorder. But I don't think that it is I don't think that the patients are able to create great muscle mass with compensation without doing any exercise.
Okay, thank you. So another question is from Dr. Rollinson. Is there a way to determine the right muscle balance for a patient between paras, flexors, glutes, etc.? The changes in the spinopelvic parameters would be a lagging indicator to any imbalance that could occur.
I think it is possible. I think that's what we need to do. I think we need to find out the best combination of the sagittal spinopelvic alignment and then the strength of all the core muscles and their interaction, and then the balance among them. We need to do more studies. We need to measure the strength of the muscles and in a quantified way, and then use different computer models, and then to see the impact. And then I think it is possible to measure the pressure effect on the disc and joints using different models with different strengths, and then the sagittal spinopelvic alignment. Yes, it is possible to measure and it's possible to determine, which I believe hasn't been done yet.
So another question from Dr. Bartoski. Would physical therapists alone be able to diagnose this, or would other methods be required?
I think the reason why some of the physical therapists are great physical therapists, they are able to identify the imbalance among the muscles. They are able to identify the mismatch between muscle strength and sagittal spinopelvic alignment and able to tailor the exercise programs individually. Yes, I think some of the physical therapists are able to do this based on their experience.
So I have another question. How about differentiating between muscle bulk and muscle tone?
The differentiating between the muscle.
The bulk that you see on the MRI, you see how much.
As a study, I think, I mean, definitely, I mean, just when I look at the MRI, I'm not able to use any quantitative measure. Yes, we'll be able to do studies and actually able to identify just able to quantify and identify the tone and strength of the muscles, which even we might be able to determine just looking at the MRIs once the studies are done.
So here's another question from Wolf on the chat. So are fibrosis and fatty infiltration, do they go together?
I mean, it seems like they do. I mean, most of the time, based on the animal studies, and I don't know which one starts first and which pathways are possible. I think the other thing we need to find out is what kind of pathways have been utilized for those changes and whether we are able to stop them at the beginning. I mean, currently, maybe I should ask Roland. And right now, we are not able to determine fibrosis on the MRI, right?
Yeah, I don't think
yeah, it is the fatty infiltration right now.
I have also a question related to muscle fatty infiltration and atrophy. Are there any studies that show how patients reverse fatty infiltration? Are there substantial? Can you reverse fatty infiltration?
I think at the beginning, I think there are studies has shown maybe in the acute and subacute stage, it might be possible. And I said that there's just a couple recent animal studies has shown that injecting mesenchymal cells into degenerative disc actually able to reverse the fatty infiltration and fibrosis process in the paraspinal muscles.
Okay. Another question from Dr. Musavi. How about paraspinal muscle endurance, shown to be the important predictor of pain in lumbar spine lordosis?
Yeah, I mean, it is the endurance is always important, and since also it is determined by the training and also the fatty infiltration, and yeah, the endurance is important as much as the fatty infiltration.
Dr. Williams had a question from the King's College London. Is there evidence from longitudinal studies that muscle weakness is the first trigger for back pain?
I mean, there are multiple studies. I cannot say first or the last. There are multiple studies has been shown that the patients with chronic low back pain, they do have atrophy in multifidus. There are fatty infiltration in multifidus, erector spinae muscles. Even there are studies has shown that unilateral low back pain correlates with unilateral multifidus atrophy. And but then, I mean, in the clinic, when we see those patients, none of them is isolated. When you see fatty infiltration in multifidus, usually you do see degenerative disc disease too. It is very rare to see someone just with the atrophy or just with myopathy without having any other dose changes.
So one last question, I think here in the chat is Dr. Mohammed Paninpour. How would postural stability correspond to strength and endurance and degenerative disc?
The posture, I mean, unfortunately, we don't have EOS in our clinic, that we are not able to look at the whole posture of the patients. But actually, even though we did just measure the sagittal spinopelvic alignment, we need to measure the whole posture to see the impact in the spine.
Okay, I had another quick question. So you talked about mode-1 changes. Why is there a reason why they develop, why that would cause fatty infiltration in the muscle?
It is the inflammation.
The pain that.
I think the fatty infiltration and fibrosis we see in the paraspinal muscles, it doesn't develop because of the pain or deconditioning, and it is really developing because of the inflammatory process in the spine. Somehow that inflammatory process in the spine, I believe, trigger the changes in the paraspinal muscles. And based on the animal studies, actually, this has been supported.
Okay, thanks, Sibel. So there's one more comment from Dr. Machunda, UCSF. So she says that fibrosis might be seen by changes in T2 and MR spectroscopy. So thanks a lot, Sibel, for this amazing presentation. And there were lots of questions, and we are still ahead of schedule, but I think we should move on to our next speaker. So thank you very much, Sibel, for this amazing talk.
Thank you.